I'm Dr. Gerald Hutchins, Chief Intensivist at St. Catherine's Medical Center in Portland, Maine. Or at least I was until I submitted my letter of resignation 3 weeks ago, effective immediately after 28 years of critical care medicine. I've held that position for the last 11 years, overseeing a Level 1 trauma ICU with 16 beds, managing everything from multi-organ failure to post-surgical complications that would make most physicians' hands shake. I completed my residency at Johns Hopkins, my fellowship in pulmonary critical care at Mass General, and I've published 43 peer-reviewed articles on hemodynamic monitoring and ventilator management. I've kept patients alive through septic shock that should have killed them in hours. I've managed ARDS cases with PaO 2/FiO2 ratios that shouldn't have been compatible with consciousness. I've seen every permutation of human physiology at its absolute breaking point. But what I'm about to tell you is the one case that shattered everything I understood about human biology and ultimately drove me to walk away from the only career I've ever known. It's the case that keeps me awake at night, staring at the ceiling, wondering how many other patients I've treated without truly understanding what I was witnessing. The medical literature has no framework for what happened in room 447 between February 14th and February 19th of this year. Neither do I. St. Catherine's is a 380-bed teaching hospital situated on Congress Street, a gray stone building erected in 1964 with additions from the 80s and 90s, creating a labyrinthine complex of wings and corridors. Our ICU occupies the entire fourth floor of the north wing, renovated in 2019 with state-of-the-art monitoring systems, Draeger ventilators, continuous renal replacement therapy machines, and enough pharmaceutical options to keep the most unstable patients chemically balanced on the knife's edge between life and death. We staff 24/7 with intensivists, critical care fellows, residents, respiratory therapists, and specialized ICU nurses who've seen horrors that would break civilian minds. The nursing station sits in the center of the floor, with glass-walled rooms radiating outward like spokes, allowing visual monitoring of every patient simultaneously. The floors are that specific shade of industrial blue-gray that every hospital seems to favor. The lighting is harsh, fluorescent, deliberately designed to prevent any shadow that might hide a change in patient status. February 14th was a Thursday, Valentine's Day, though that means nothing in critical care. I arrived for my shift at 6:47 a.m., my usual 17 minutes early, carrying my third coffee of the morning and reviewing overnight notes on my tablet. The unit was relatively stable that morning. Bed assignments included 2 post-operative cardiac surgeries doing well, 1 traumatic brain injury from a car accident on I-295, a septic pneumonia who'd been with us for 6 days, and several others with the usual ICU pathology. Morning rounds proceeded normally. We adjusted ventilator settings on the TBI patient, discussed weaning pressures on the sepsis case, and ordered another echocardiogram for one of the cardiac patients whose ejection fraction wasn't improving as expected. At 11:23 a.m., the emergency department called with an incoming admission. 58-year-old male Raymond Kowalski, found unresponsive in his apartment by his landlord. Initial assessment showed severe respiratory distress, altered mental status, hypotension with a systolic in the 70s, and a preliminary diagnosis of possible aspiration pneumonia with septic shock. Paramedics had intubated him in the field. He arrived on our floor at 11:41 a.m., and we transferred him to room 447, the corner isolation room we typically reserve for immunocompromised patients or those requiring contact precautions. His initial presentation was textbook septic shock, temperature of 103.7 degrees Fahrenheit, heart rate 134, blood pressure 73/42, despite 2 liters of normal saline. His Glasgow coma scale was 3T, completely unresponsive, intubated, no eye opening, no motor response. Pupils equal and reactive at 3 millimeters. We immediately established central venous access through his right internal jugular, started norepinephrine at 0.12 micrograms per kilogram per minute, began broad-spectrum antibiotics with vancomycin and piperacillin tazobactam, and drew labs for everything. Complete metabolic panel, complete blood count, lactate, procalcitonin, blood cultures ×2. Chest X-ray showed bilateral infiltrates consistent with aspiration pneumonia. His oxygen saturation was 88% on 100% FiO2 with PEEP at 10, which concerned me. That suggested significant shunting and poor gas exchange, even with maximal oxygen support. I'd seen this pattern hundreds of times. Aspiration pneumonia progressing to ARDS, multi-organ dysfunction from sepsis, the usual cascade that requires aggressive support while antibiotics work and the immune system battles infection. Nothing about Raymond Kowalski's initial presentation suggested anything unusual. He was overweight, approximately 220 pounds, with a thick gray beard and weathered hands that suggested outdoor manual labor. According to the limited social history we'd obtained, he lived alone, worked in construction, had no known family in the area. The landlord reported he'd seemed fine 2 days prior. Jennifer Caldwell, one of our senior ICU nurses who'd been with the unit for 15 years, took primary responsibility for his care. At 2:15 p.m., she documented his first set of ICU vitals. Blood pressure had improved to 94/53 on the norepinephrine, heart rate 118, temperature down slightly to 102.9 degrees Fahrenheit. Oxygen saturation holding at 90% on the ventilator settings. His lactate came back elevated at 6.7 millimoles per liter, indicating significant tissue hypoperfusion. White blood cell count was 24,000 with a left shift. Creatinine elevated at 2.3, suggesting acute kidney injury. Everything tracked with severe sepsis. The first irregularity occurred at 4:33 p.m. Jennifer came to find me at the nursing station, her expression puzzled. "Dr. Hutchins, can you look at Kowalski's monitor? His waveforms are doing something strange." I walked to room 447 and studied the bedside monitor. Raymond Kowalski lay motionless on the bed, the ventilator cycling rhythmically, delivering breaths with its characteristic mechanical hiss and click. But his arterial line waveform was demonstrating a pattern I'd never encountered in 28 years. The systolic upstroke appeared normal, but the dicrotic notch, that small secondary peak that indicates aortic valve closure, was appearing twice per cardiac cycle instead of once. It would show the normal pattern, then for 3 or 4 beats, display this doubled notch, then revert to normal. I watched it for 2 full minutes. "Check the transducer," I said. "Probably air bubbles in the line causing artifact." Jennifer flushed the arterial line, rezeroed the transducer, and we watched again. The pattern persisted. Double dicrotic notch for several beats, then normal, then double again. The rhythm was irregular, unpredictable. But Kowalski's actual pulse, when I palpated his radial artery, felt entirely normal. His heart rate on the EKG remained steady at 116 beats per minute with normal sinus rhythm. The arterial line reading showed blood pressure of 98/56, perfectly consistent with his clinical status. "Get a different transducer," I said. "This one might be defective." We replaced the entire arterial line setup with fresh equipment. The pattern continued. I stood there staring at that monitor for 10 minutes, mentally reviewing every possible explanation. Arterial line artifact, defective equipment, pneumatic interference from the ventilator, electrical noise. But the waveform was too clean, too precise to be artifact, and it made no physiological sense. The dicrotic notch represents a specific hemodynamic event, the brief pressure increase when the aortic valve slams shut. You can't have it happen twice in a single cardiac cycle. The aortic valve doesn't close twice. That would require the heart to generate 2 separate systolic ejections per beat, which is anatomically impossible. "Let's get an echocardiogram," I said. "I want to visualize what his heart is actually doing." We performed a bedside transthoracic echo at 5:18 p.m. I did it myself, placing the probe in the peristernal position, then apical, then subcostal, sweeping through every standard view. Kowalski's heart appeared completely normal. Left ventricular systolic function was actually quite good for someone in septic shock, with an estimated ejection fraction around 55%. Valves opened and closed normally. No vegetations, no structural abnormalities, no pericardial effusion. The heart contracted once per beat, exactly as expected, ejecting blood in a single coordinated systole followed by diastolic filling. Nothing that could possibly explain the arterial waveform we were observing. "I don't understand this," Jennifer said quietly, echoing my own thoughts. "Equipment malfunction," I said firmly. "Has to be. Let's change to a different monitor entirely." We moved Kowalski's arterial line to a completely different Philips monitoring system, one in a different room that we wheeled in. Same pattern. Double dichrotic notch, irregular appearance, no correlation with any known physiological phenomenon. I documented it in the medical record as arterial line artifact, etiology unclear, and moved on with evening rounds. There were 12 other critically ill patients who needed my attention. At 9:47 p.m., Jennifer paged me. "Dr. Hutchins, you need to see Kowalski's labs." His evening labs had returned. The results made me read them 3 times to ensure I wasn't misunderstanding. His lactate, which had been 6.7 millimoles per liter 6 hours earlier, was now 1.2 millimoles per liter. Normal. His creatinine had dropped from 2.3 to 0.9. His white blood cell count had decreased from 24,000 to 16,000. In 6 hours, his markers of septic shock had improved more dramatically than I'd ever witnessed. Lactate clearance of that magnitude typically takes 24 to 48 hours, with aggressive resuscitation. His kidney function had essentially normalized. The timeline made no medical sense. "Did the lab mix up samples?" I asked. "I thought the same thing." I called them. They confirmed it's his specimen, drawn at the correct time, processed appropriately. I went to his room. Kowalski remained deeply sedated, intubated, the ventilator breathing for him. His blood pressure was now 112/64 on a reduced dose of norepinephrine. Oxygen saturation 94% on slightly lower FiO2. Clinically, he looked better. His skin was warmer, less mottled, but the rapidity of improvement defied everything I knew about septic shock physiology. "Well," I said, trying to sound confident, "sometimes patients surprise us. He's young enough. Maybe his immune system is just mounting an exceptional response to the antibiotics." But I didn't believe it. Antibiotics don't work this fast. The vancomycin and piperacillin tazobactam had barely been in his system for 10 hours. And even if they'd immediately sterilized every bacterium in his bloodstream, which is impossible, the inflammatory cascade of sepsis doesn't reverse this quickly. The cytokine storm, the endothelial dysfunction, the capillary leak, all of those processes take days to resolve, not hours. I went home that night and couldn't sleep. I kept seeing that arterial waveform in my mind, that doubled dichrotic notch that shouldn't exist. I reviewed Kowalski's chart on my phone at 2:30 a.m., reading every note, every lab value, searching for something I'd missed. Friday morning, February 15th. I arrived at 6:44 a.m. I went directly to room 447. Raymond Kowalski was awake. His eyes were open, tracking movement. He was still intubated, still on the ventilator, but he was following commands. When I asked him to squeeze my hand, he did. When I asked him to wiggle his toes, he complied. His Glasgow coma scale had gone from 3T to 10T overnight. This was impossible. Patients don't emerge from septic coma this quickly. The sedation alone should have kept him obtunded for another 12 to 24 hours. "Mr. Kowalski," I said, "I'm Dr. Hutchins. You're in the ICU at St. Catherine's Hospital. You were very sick, but you're getting better. We're going to take good care of you." He nodded slightly. His eyes were clear, focused. There was no confusion, no post-septic delirium. He was simply awake and alert, as if he'd just been taking a nap instead of being at death's threshold 20 hours earlier. His morning labs showed further improvement. Lactate 0.8 millimoles per liter, creatinine 0.7, white count 12,000. Chest x-ray showed improved aeration, with the bilateral infiltrates already beginning to clear. We were able to reduce his oxygen requirements to 50% FiO2. His blood pressure remained stable as we weaned off the norepinephrine entirely by 10 a.m. At 11:15 a.m., we attempted a spontaneous breathing trial to assess whether he could breathe independently of the ventilator. Standard protocol requires at least 30 minutes on minimal settings to evaluate respiratory drive, muscle strength, and gas exchange. Most patients emerging from severe pneumonia and sepsis can't pass this trial for several days. Kowalski passed in 8 minutes. His respiratory rate was 16, tidal volumes adequate, oxygen saturation 96% on 40% FiO2 through the endotracheal tube alone. Dr. Patricia Chen, our critical care fellow, looked at me with raised eyebrows. "This is remarkable recovery," she said. "Yes," I replied, "it is." We extubated him at 11:47 a.m. He tolerated it without difficulty. Placed on 4 liters of oxygen via nasal cannula, he maintained saturation at 95%. His first words were, "How long have I been here?" "Since yesterday morning," I told him. "You had severe pneumonia and sepsis. You've been critically ill." "I feel fine, man," he said. His voice was raspy from the endotracheal tube, but strong. "Actually, I feel really good." That statement chilled me. Patients who've just been extubated after severe sepsis don't feel really good. They feel exhausted, weak, disoriented. They have muscle wasting from immobility and catabolism. They struggle with basic tasks. Kowalski was sitting up in bed unaided, reaching for his water cup without tremor or weakness. He'd lost approximately 40 hours to sedation and critical illness, yet he showed no physical deconditioning whatsoever. Over the next 18 hours, his improvement continued at an impossible pace. By Saturday morning, February 16th, he was ambulating in his room without assistance. His oxygen saturation remained normal on room air. Repeat chest X-ray showed near complete resolution of the pneumonia. His laboratory values were entirely normal. 72 hours after arrival in florid septic shock, Raymond Kowalski was medically stable for discharge from the ICU. "This doesn't happen," Dr. Chen said to me during Saturday rounds. "I've never seen resolution this rapid." "Neither have I," I admitted. "Should we be concerned about, I don't know, something we're missing?" "Run every test you can think of," I said. "Comprehensive metabolic panel, inflammatory markers, repeat cultures, viral panel, autoimmune workup. If there's an explanation, I want to find it." Every test came back normal or negative. His blood cultures showed no growth. His procalcitonin, which had been elevated on admission, was now undetectable. His CRP had dropped from 187 milligrams per liter to 3 milligrams per liter. These were values consistent with someone who'd never been sick at all, not someone recovering from near-death septic shock 3 days prior. On Saturday afternoon, I sat down with Kowalski to take a detailed history, something I hadn't been able to do while he was intubated. I asked about his medical background, his lifestyle, any supplements or medications he might take. He denied any unusual health practices, no alternative medicine, no experimental treatments. He worked construction, lived alone since his divorce 8 years ago, rarely got sick. He couldn't remember anything about the days before his hospitalization, which was unsurprising given the severity of his illness. "Do you feel any different?" I asked him. "Anything unusual about your body, your perceptions, anything at all?" He thought for a moment. "No, doctor. I just feel normal. Better than normal, honestly. I feel great." I sent him to a regular medical floor Sunday morning, February 17th. He no longer required ICU level care. I documented his case extensively, noting the unprecedented rapidity of recovery, the unexplained arterial line findings, the laboratory improvements that defied normal kinetics. I made a mental note to write it up as a case report, possibly submit it to critical care medicine or CHEST. It would make for interesting academic discussion. Then, on Monday, February 18th, another patient arrived with an eerily similar presentation. Harold Brennan, 63-year-old male, found unresponsive at home, severe pneumonia with septic shock, intubated in the field. Admitted to the ICU at 3:17 p.m. Initial lactate 7.2 millimoles per liter, creatinine 2.6, white count 26,000, hypotensive requiring norepinephrine, Glasgow Coma Scale 3T. I assigned him to room 449, 2 doors down from where Kowalski had been. At 8:45 p.m., Jennifer called me to room 449. "Dr. Hutchins, look at his arterial line. The double necrotic notch, exact same pattern, appearing irregularly, unpredictable, physiologically impossible." I felt my stomach tighten. Change all the equipment, I said. Different transducer, different tubing, different monitor. We did. The pattern persisted. His labs the next morning showed the same dramatic improvement. Lactate 1.4 millimoles per liter. Creatinine 0.8. White count 15,000. By Tuesday afternoon, he was awake, alert, following commands. We extubated him Wednesday morning. He was medically stable for floor transfer by Wednesday evening. What the hell is happening? Dr. Chen asked me directly. I don't know, I said. I was staring at Brennan's chart on the computer, comparing every value side by side with Kowalski's from the week before. The trajectories were nearly identical. The timeline of improvement matched within hours. 2 patients, no apparent connection, both with severe septic shock, both with impossible arterial waveforms, both recovering at a rate that violated everything I understood about critical care medicine. I called an informal meeting with the ICU attending physicians, our 3 critical care fellows, and the nursing leadership. We reviewed both cases in detail. I showed them the arterial line tracings, the laboratory trends, the imaging. Everyone agreed the recovery was unprecedented. No one had an explanation. Dr. Robert Vasquez, who'd been an intensivist for 35 years, longer than anyone else on staff, said what we were all thinking. This shouldn't be possible. Not once, and certainly not twice in the same week. Equipment malfunction? Suggested Dr. Lynn Morrison, one of the other attendings. We replaced every piece of monitoring equipment multiple times in both cases, I said. Different manufacturers, different rooms, different everything. Same results. Laboratory error? Different lab techs, different shifts, repeat confirmatory testing. The values are real. Some new antibiotic-resistant strain that responds differently to treatment. Cultures are negative in both cases now, and the antibiotics we used are standard. Nothing experimental. We sat in silence for nearly a minute. Finally, Dr. Vasquez said, Gerald, I think you need to report this to the state epidemiology office. If there's some environmental factor, some infectious agent we're not detecting, we need to investigate. I filed a report that afternoon. I also contacted the CDC through their Emergency Operations Center, describing the cluster of cases with unusual presentation and recovery. They assigned an Epidemic Intelligence Service officer to review the data. After 3 days of investigation, their conclusion was that while the cases were medically unusual, there was no evidence of a novel pathogen, no environmental toxin detected, and no public health threat identified. They documented it as atypical clinical course of community-acquired pneumonia with sepsis, etiology uncertain. That non-answer satisfied no one, least of all me. Raymond Kowalski was discharged from the hospital on February 20th, exactly 6 days after admission, walking out under his own power with normal vital signs and a prescription for a short course of oral antibiotics. Harold Brennan was discharged on February 22nd with identical instructions. I never saw either of them again, but I couldn't stop thinking about them. I reviewed their charts obsessively. I went back through our ICU database looking for any similar cases in previous years. I found none. I read every article I could find on rapid recovery from septic shock, on unusual arterial waveforms, on any phenomenon that might explain what I'd witnessed. Nothing came close. The arterial line findings haunted me especially. That double dichrotic notch meant something. It represented some physical reality, some actual hemodynamic event occurring in their circulation. But what? The heart doesn't contract twice per beat. Blood doesn't flow backward through closed valves. The laws of physics don't change for individual patients. Unless I was wrong about what I understood, unless there were aspects of human physiology that medical science hasn't adequately explained, unless the models we use, the Frank-Starling curve, the oxygen delivery equations, the pharmacokinetics of pressors and antibiotics, unless all of those models are incomplete approximations of something far more complex. I started questioning other cases. How many times had I seen unexplained recovery? How many times had patients survived when our predictive models said they shouldn't? How many times had I attributed it to resilience or fighting spirit or simple statistical variation when perhaps something else was occurring that I lacked the framework to understand? The doubt became corrosive. Every patient I managed after Kowalski and Brennan, I found myself second-guessing. Were the treatments working through the mechanisms I understood, or through something else? Was I actually saving lives, or was I just present when patients healed themselves through processes I couldn't fathom? 28 years of medical education and clinical experience suddenly felt inadequate, built on foundations that might be fundamentally incomplete. I couldn't sleep. I lost weight. My hands started shaking during procedures, something that had never happened in nearly 3 decades of critical care. Dr. Morrison noticed during a central line placement and asked if I was okay. I told her I was fine, but I wasn't. I was disintegrating. On March 8th, I walked into the office of Dr. Thomas Reynard, our chief medical officer, and placed my resignation letter on his desk. "Gerald, what's this about?" he asked, reading the first few lines with growing concern. "I can't do this anymore," I said simply. "Because of those 2 sepsis cases?" "Gerald, unusual presentations happen. Medicine is full of things we don't fully understand yet. It's not just that. It's what it means. If I don't understand what happened there, if none of us do, then what else don't I understand? How many other patients have I treated without actually knowing what I was treating? How much of what we do in critical care is just performing rituals because they usually work, without understanding why?" "That's the nature of medicine," he said gently. "We work with incomplete knowledge. We do our best with what we understand." "My best isn't good enough," I said. "Not anymore." He tried to convince me to take a leave of absence instead, to see a therapist, to reconsider. But my mind was made up. I worked my final 2 weeks providing coverage while they searched for a replacement. On March 22nd, I walked out of St. Catherine's Medical Center for the last time. I'm writing this now from my home in South Portland, 3 weeks after my last shift. I haven't practiced medicine since. I haven't even opened a medical journal. I spend my days walking along the Eastern Promenade, watching the ocean, trying to make peace with uncertainty. The question that haunts me isn't what happened to Raymond Kowalski and Harold Brennan. The question is how many other patients, over 28 years, thousands of cases, experienced something similar, and I didn't notice because I was too focused on the protocols, the algorithms, the expected patterns. How many mysteries did I miss because I assumed I understood what I was seeing? Medicine teaches us to trust our training, to rely on evidence and mechanism. But what happens when the evidence contradicts itself? What happens when the mechanisms we're taught turn out to be incomplete maps of a terrain far stranger than we imagined? I don't have answers. I don't think anyone does. All I know is that in room 447 at St. Catherine's Medical Center, something happened that shouldn't have been possible. And it happened again in room 449. And somewhere right now it's probably happening again to another patient in another ICU. And another doctor is writing it off as remarkable recovery without looking deeper at what remarkable truly means. I hope they're better equipped to handle that knowledge than I was. Because once you see beyond the edge of what you understand, you can't unsee it. And sometimes the only honest response is to step back and admit you never really understood it all.